Okay, good morning, everyone. Welcome back. Today is Tuesday, November 10th, and we have a very special group of speakers today. We're really thrilled to have these four tremendous researchers here who are with us today to speak about gender, family, and home and work during this critical time in our pandemic. Before I pass it over to Alan to introduce our speakers, I just wanted to discuss a few things that have happened since our last class, which was amazingly less than a week ago. And so much has continued to shape our country. It's hard to imagine much more happening in the span of what is basically 5 days. Obviously, the results of the election have been determined. There is still obviously ongoing back and forth between the two administrations, but I think in the context of COVID, what this potentially means is a huge shift in how the national response is going to now be leveled across our country. And I can think of no better representation than to have tremendous number of phenomenal people who are on the new task force that's assigned to ensure that we have an appropriate response to this pandemic. And as you know, one of our prior speakers here, Dr. Atul Gawande, is one of those members. And as someone who also works at the Brigham, I'm thrilled to see that my co-resident, Vivek Murthy, who's a dear friend of mine, is co-chairing that. As well as Marcela Nunez-Smith, who was a resident who was just a year in front of me. So we have 3 members of the Brigham community who are on this task force, and just another reminder of the expertise we have here at Harvard across all of these disciplines. It's really, for me, a welcome sight to see this expertise. And I see this as an opportunity to bring medicine, public health, and science, and addressing issues of diversity and inclusion back into the conversation around our COVID response. So I wanted to at least mention that in this context. I also wanted to mention some big news out from Pfizer yesterday. As you recall, we had a discussion devoted entirely to vaccines. And as you all hopefully have seen in the news, that we're seeing some very promising efficacy of a vaccine coming out of Pfizer. We have a lot we still need to learn, particularly related to long-term safety, as well as supply chain issues, particularly in relation to the need for this to have what we call a cold chain, and the need for this to remain basically a very cold vaccine to be administered, which brings in all sorts of issues of distribution globally. So that's something to be watching out for. And I just wanted to flag that for your attention. And finally, the last point I'll make before I hand this off to Alan is, the very personal nature of this conversation for me as a physician, married to another physician who has a child. We are very much experiencing this moment. This is a very personal space for me. And I've looked towards these leaders for their rigor that they bring to this conversation. And I'm so eager to be learning from them today about the impact that we have seen COVID have, particularly in the context of gender and family and work. And so without further ado, I'm going to pass it on to Alan to introduce our amazing speakers today.
Thanks, Ingrid. I would just reiterate one thing that you just observed. I'm so used to teaching historical aspects of disease and what happened in the past, sometimes thinking about its contemporary relevance, but to be living through the pandemic, to be experiencing this really, crisis surge at this time of the year, not just here in the United States, but around the world, and to watch an election and a transition in a major country in the midst of a pandemic is really quite a remarkable story in and of itself. And I think it's sometimes a struggle in the course of the course to realize just how momentous and difficult and divisive and important these kinds of changes are. I would also just say one thing, the vaccine is really just a remarkable accomplishment, but the issues of how to get vaccines into people and who they will go to and how we will get them there may turn out to be just as challenging as the scientific issues were around the production of a safe and effective vaccine. So those will be things for us to watch closely. Today we have a really remarkable session on one of the critical issues that the epidemic has revealed and impacted. And we started the course with the notion that we would look at the pandemic as affecting almost all aspects of life and look at it as revealing some of the most fundamental inequalities in global societies and especially here in the US. And we've looked at some of those things already about essential work, frontline workers. We've looked a lot at questions that are associated with structural racism and health disparities. But today we really want to examine closely fundamental problems of gender and work and the labor force and issues that are deeply historical, but are illuminated in extremely powerful ways in the context of the pandemic. And fortunately, we have 4 guest faculty members today who have really explored problems of gender and equality in their work, but they've been looking very critically at how their understanding of those problems are reflected and refracted in the pandemic, and how the pandemic is affecting fundamental issues of gender, inequality, income, and work. Our first speaker today will be Dr. Hannah Bowles, and she is the co-director of the Women in Public Policy program at the Harvard Kennedy School, where she is also a senior lecturer in public policy and management. And Dr. Bowles has worked for a long time on fundamental issues of gender, race, and identity, fairness and justice, and especially women's leadership and negotiation. And it's really fantastic to get her reflections on how the pandemic has affected and will affect some of those profoundly important issues moving forward. Our second speaker will be Professor Claudia Goldin. And Professor Goldin is an economist in our Department of Economics. She also has a leadership position at what is well known in Cambridge as NBER, but stands for National Bureau of Economic Research. And that's a research institute that brings together economists and scholars from around the world to focus on critical problems. She leads a study group there on gender in the economy. Professor Goldin's work is really notable, and I appreciate it especially because it's deeply rooted in historical scholarship on labor and the history of labor, and especially women's labor. But her work is also focused on issues that are crucial in thinking about long-term aspects of women in the workforce, inequality in wages and the wage gap. And she's really the most remarkable scholar of the history of the economy as it has affected women through the course of the, really going back to the 19th century, but into the 21st century. Our third speaker will be Professor Julie Battilana. And Professor Battilana is a professor at the Harvard Business School in their unit on organizational behavior. And I think she's our first speaker from HBS. Ingrid and I worked very hard to try to engage faculty across the university for the course. And it's wonderful to have a representative from the business school here today. Her work is also centered on fundamental questions of inequality, work, she has focused on what's called divergent changes. And some of these are purposeful, in which you would say, how do we change an organization to reflect issues of equality and fairness? But also, she has thought deeply about the divergent change that COVID really presents and the recognition of fundamental inequalities, especially relating to gender as it relates to COVID, but also some of the really powerful potentials in the pandemic to rethink issues of democracy, gender, inequality, and justice. And she's the author, the co-author of a major treatise called The Working Manifesto, and it's been widely circulated. Hundreds of scholars, thousands of scholars, I think, have signed it around the world. And it's really, I know you have a link to it in your syllabus, but it's a remarkable document about the potentials inherent in the pandemic to rethink how things are. And finally, our fourth speaker today is my friend and colleague from the Department of the History of Science, Professor Sarah Richardson, who also has a joint appointment in studies of women, gender, and sexuality, where she's currently the chair. And Professor Richardson's work centers on the relationship of our understanding of the biological differences associated with gender, but in a deep social, cultural, and political context. And her work ranges across fundamental issues of gender, sexuality, philosophy, and history, but she has recently been the founder and co-director of the Gender Sci Lab, and they are looking explicitly at gender differences in the pandemic and what they mean, how to interpret them, how to count them. And I think there's a link to her COVID-19 gender tracker on our syllabus, but we'll make sure we put it up. But it's a remarkable initiative to try to understand the role that gender plays in the pandemic. So as you can see, we've been able to get some really great thinkers today together to think about issues of gender inequality and how they intersect with other fundamental inequalities like race and class. So we'll start with Dr. Bowles. Thank you very much.
Thank you for your kind introduction. Let me put up my slides. So I anticipate that I will be flagging some points that the subsequent speakers will delve into more deeply. I'm going to talk about gender in the COVID era. I know you all have been talking about how crises reveal fault lines in societies, the cracks in the infrastructure, the weakest points. Crises are also an opportunity for change, for potentially transformational change. So what I want to talk about both is urgent current concerns, but also higher hopes. So I'm assuming my slides are showing and I can proceed. Okay, great. So I also, when I talk about gender, I want to draw a distinction between gender in terms of how that is assigned to the way people self-present, and gender as a kind of archetype. So, and I'm going to talk about the implications of as I see them from COVID-19 in kind of both respects. So there are these archetypes, and I'm simplifying here for the sake of time, between a kind of archetype of masculine dominance, of the capacity to have power over, to control, to compete, and what is considered kind of the feminine archetype of care. Care within the home, certainly within the family, but also within the community. And these larger gendered archetypes tend to get assigned to people who self-present as male or female, that women are expected to be feminine, men are expected to be masculine. This has historically been, even more tightly the case than it is today. I think we are growing now in our recognition that women can be both masculine and feminine, as can men. So I want to talk about people and the implications of the statistical analyses. How are we thinking about the implications of the current crisis for men and women and people who are transgender or identify as transgender or queer. But I also want to talk at the end about these ideas of gender as an archetype and whether or not there might be some potential there for positive transformational change. So let me start with my urgent concerns. The first one is job losses, and not only job losses, but job departures. So those areas, I've got here to the right a graphic produced by the National Women's Law Center based on data from the Bureau of Labor Statistics, showing that the current unemployment rate right now hovers around 6% overall, but it is higher for women of color and for even higher for women with disabilities. It's also higher for young women when you combine, according to this report, young women with Black women, you get, again, an unemployment rate of something like 15%. So what we're seeing is that some of those sectors that have been hardest hit, retail, hospitality, are those that are where women are heavily represented, but in particular, women of color. And so there has been the discussion about a she session. Now, in part, this has to do with women losing jobs in these sectors that are most affected. But the other critical factor in a component of the she session is the sudden and sustained backflow of caregiving and educational labor into the home. And so what you're seeing is that because that care labor typically falls on women, you're seeing women struggling to balance both that unpaid care labor and their paid work, so that they are not only reducing their hours, but the statistics seem to be suggesting that they are actually withdrawing from paid labor. And Alicia Modestina, who's been a mentee of Claudia Goldin, who you'll hear from, she was so smart in her studies of the recession to actually ask, if you've lost your job, why? And she found that disproportionately women are reporting that they're stepping out of the workforce, unable to sustain labor because of conflicting caregiving concerns. Now, I want to highlight, to take also a global perspective, that another sector that has been acutely affected by the pandemic is the informal sector. So globally, a majority of workers are actually in the informal sector. And my little pink and blue graphic gives you a little sense of what the informal sector is if you're not familiar with that term. But these are people who are working off the grid, right? So these are not the people to whom policies are being directed, whether that's loans or provision of PPE or health coverage or anything like that. So you've got masses of people are kind of falling out of the formal policy space who are among those most affected. And again, what you see is that women are overrepresented in this informal sector. Another factor that affects people is domestic violence. We know from past pandemics and economic downturns that both pandemics and economic crises increase the rates of domestic violence. Again, thinking about those least privileged, there is also a relationship between economic privilege and one's risk of domestic violence. Anybody is vulnerable to domestic violence, but evidence suggests that there are higher rates of domestic violence among the underprivileged. And so we also know that not only is this harm occurring at higher rates, but again, we know from past research that there's a negative association between economic participation and the experience of abuse. So this may be another factor that dims the potential for women and people who are vulnerable to participate in the economy. I want to go back to bodies and how people self-present. There's a lot of discussion right now, as I mentioned already, about the she session and the disproportionate burden that women are carrying as a result of the pandemic. But we shouldn't forget, we don't have as good statistics on the situation of people who are transgender, non-binary, or identify as queer. But we know that those populations are typically among the least economically privileged and among those most vulnerable to domestic violence. And so I think we have to be keeping in mind that that is another source of gender inequality that we should be finding ways of addressing. Okay, higher hopes. Can we turn this toward a positive? Where do I see a kind of glimmer of light in all of this? One is that historically, in times of crisis, particularly, our heroes have been associated with men. They are the soldiers, the firefighters, the police officers. Typically, we associate our heroes very often with masculinity. And what is happening here in the current crisis is that we have women at the front lines being clearly recognized as the heroes in response to the pandemic. And in some parts of the world, I've seen statistics showing that, upwards of 90% of the frontline workers on the pandemic are women. So you're seeing this kind of loosening of a notion of heroism with masculinity and a recognition of femininity and care work with heroic labor for the society. We also have seen a celebration of women as leaders. And also we've just seen in the past week, the election of a US president whose leadership narrative was actually being a single parent and having the capacity to empathize and care for others. So what we have right now is an ascendance of, again, these the feminine archetype with our leadership. Last thing I'll highlight is that we're also seeing an ascendance of recognition of the importance of care work also in relation to paid labor. So we're seeing employers actually, working desperately to help employees reconcile their unpaid care labor, and to also there's growing access to remote work. We're also seeing survey evidence suggests that at least for egalitarian couples, men are participating more in care labor. So Claudia will pick this up more, but she has argued that this is sort of the last stage, I think at least for college educated women, of how to close the gender gap if they didn't have to pay for more predictability and flexibility in their work. And there may be hope in this pandemic for a more gender equality in family care, but also more integration of flexible work into paid labor. So I'll leave it there, and I'm so eager to hear from our other speakers.
Thank you so much. Those are such important ideas. And I have to admit, the course has been so sobering in so many ways, but the recognition that there could be positive changes on the other side of the pandemic seems to me an important thing for us to be thinking about now, if those things are going to be possible. So our next speaker is Professor Goldin.
Good morning, everyone. So never before have those working on the front lines been asked to bring danger into their homes. Never before have we needed to shut down the economy to get it running again. Never before has a recession impacted women more than men, that is a recession in the US. And never before has the care sector been so related, so intertwined with the economic sector. Women are now almost 50% of the labor force. And so we need to make certain that they do not sacrifice their jobs because of care issues. And we also need to make certain that they don't sacrifice their children for their careers and their jobs. In mid-March of 2020, we descended from BCE, which means before the Corona era, into something that I'll call DC, which is during Corona. And most workers sheltered in place and worked from home. And I'm going to be focusing on a special group which is heterosexual couples, college graduate, employed adults, and their families. And I use the American Time Use Survey, known as the ATUS, to compute childcare hours of mothers and fathers by the age of the youngest child. And that's on the horizontal axis is the age of the youngest child. These parents and their children are clearly, as Hannah indicated, in a very fortunate category. The childcare, the weekly hours of mothers are given here, and this is BCE in the old world, and they're given by these dark blue bars, and the fraction of total parental childcare hours that women did is given above the bars. Before the Corona era in BCE, college graduate employed mothers living with college graduate employed fathers, and these are all parents, were doing around 60% of total childcare hours. That does not include housework, for which women did about 70%. In mid-March 2020, almost 90% of school-age children were not physically in school, and most childcare facilities had been shuttered. That greatly increased childcare demands, but there was also something else, and that is that there was more parental sharing, since in many households, both parents were at home full-time. And consequently, the fraction of childcare performed by the mothers fell, even as total childcare hours, you can see here, just about doubled. The light blue bars denote the hours that mothers contributed to childcare, and as I said, the fraction that they did is also given. And these are derived from a host of surveys that were done in April of 2020 and a ton of different assumptions. In September of 2020, we moved into a new world, into what I call the AC/DC world, because it's after Corona, but it's still during Corona, and even more so now. Draconian pandemic restrictions were partially lifted. Daycare centers opened in most states in early summer, but it is likely that far less than half of all the nation's public school children are in school full-time or will soon be in school full-time. In addition, about 1/3 of adults who worked at home in May had returned to their workplaces at least part-time by September. And among college graduates, about 40% had never worked from home, although women did so more than men. It is likely that in this AC/DC world, total childcare and homeschooling hours are maybe about halfway between what existed BCE and what existed DC in March or April of 2020. Since schools and childcare are available in much of the country around half the weeks, possibly less now. For most college graduate workers, earnings and promotions rise with respect to uninterrupted hours of work, but children are now at home far more. And so the usual issues faced by all these couples, BCE, have been greatly magnified. One member of the couple will go back to work full time and be on call at the office as well. And the other member of the couple will work from home and take care of the kids. And that parent will also be on call at home. And if history is any guide, or if district website graphics are, and this is a graphic from the Chicago Public Schools, if they are any guide, the person who will be who will work at home and take care of the children's school needs will be a woman. There may have been no net gains for working women in the move from the DC world to the AC/DC world. Their total hours are given, as I said, by the green bars. What they gained from school and daycare openings, they have lost from lower parental help at home. In consequence, their total hours remain about the same in the DC world, but their share of total childcare increases, as you can see. For most mothers, the AC/DC world has become the BCE world on steroids. Let me end by saying what a solution might be. We need to find a safe way to have classes for children, for their futures, for their parents, and in particular, for women. As in the Great Depression of the 1930s, we have highly talented and unemployed or underemployed labor who could be put to work educating children, particularly those from low-income families. We once had a Works Progress Administration CCC program, and we need a new CCC program, what I've called a civilian college corps, to free parents, especially women, to return to work and give work experience to unemployed college students. The Corps could support beleaguered parents, too exhausted to correct essays and too confused to help with algebra. Other Corps members could be in the classroom helping districts cope with reduced numbers of older teachers. In our AC/DC world, we must reduce the cost to parents of educating and caring for their children for the sake of the entire economy, for women in particular, and to improve learning for the future generation. Thanks.
Thanks so much, Professor Goldin. It's really fascinating because I tend to think, much like in medicine, we think of a single disease at a time. We think of one social institution at a time, home, school, and your talk really represents the necessity of integrating how we think about those things. One idea that came up earlier in the course around provision of healthcare was the historical value of community healthcare workers, especially in a time of a pandemic. And I see your proposal of a civilian corps of people who can assist in childcare and teaching to be similar in some ways to these notions about how to rely on community efforts in certain ways to relieve critical needs. So it's really a kind of fascinating connection to other elements that we've discussed. So our next speaker is Professor Battilana. So thank you very much for being here.
Everyone, pleasure to be here. Thank you, Alan. Thank you, Ingrid, for inviting me to join. I'm delighted to join this wonderful group of researchers and scholars today. So what Alan and Ingrid have asked me to do today is to tell you about an initiative that I contributed to co-launching, which is all about a critical issue related to democratizing work. And this initiative has important implications for women, but what I should say from the beginning is that it's not focused exclusively on women. So I'm going to now talk about this initiative and help us think through the future of work, and I highlight implications for gender issues and gender equality, but will not concentrate only on that dimension, and I'll be building on what Claudia and Hannah just shared. So I'll start by saying that we're facing a crisis that is clearly a multidimensional crisis. If we think about the situation, and I know that's something you've been covering over the course of the semester, we're obviously facing a tragic health crisis, but the crisis is also a socio and economic crisis. And Hannah and Claudia just very eloquently captured some critical aspects of this crisis for women. I know that you've already covered the importance of this crisis also and its implication for minorities. The truth is that, as we know, this crisis, the pandemic, has increased existing inequalities. Now, I'll say that we're facing a crisis that's not only a health, a social, and an economic crisis, but we are also facing an environmental crisis that has been ongoing for a long time now, and that represents an existential threat to human life, but not only to all forms of life on this planet, really. And I would say that part of the roots of this multidimensional crisis can be traced back to the shareholder value maximization model that has been dominant in the economic realm over the past 50 years, and that has contributed to a concentration of wealth, right, and power in the hands of a few, and to the destruction of the planet. So we're now facing this important moment where we can either stay the course, but if we stay the course, we know what's going to happen. It's now documented by research. We will further increase inequalities for certain categories of population. And we're talking today about women and gender, but you've already covered other important categories, right? Again, minorities, racialized communities, as well as people who belong to different kinds of social and socioeconomic classes. But so if we stay the course, we'll increase inequalities and we further destroy the planet. So it's the desire to think about how to rebuild and how to think about our society and our economy differently that led me in the spring to get together with two of my colleagues, Isabel Ferreras and Dominique Méda, and we got together asking ourselves two questions. What does this multidimensional crisis teach us, and what can be done about it? And so first thing is, what does it teach us? It's pretty obvious, you'll say, that human beings are much more than mere resources, right? And we're facing a paradox because we've put an increased emphasis on essential workers, and the term is so well deserved, and it's so critical to recognize the importance of their contributions. But yet these workers were, and I still treated as anything but essential. If you think about levels of compensation, and if you think about, do they have a say when it comes to the strategic decisions of their organizations, the companies that employ them, right? And so what seemed obvious to us at the time, and also is still, I think, very current now, is the need to better recognize the contribution of all these workers, including women workers, who are quite often, as Hannah and Claudia mentioned, in more complicated situations and whose work is not being recognized. So the critical thing is recognizing the importance of the contributions of these workers and putting the people and the planet back at the center of our economic system. And so that led us to write an op-ed that we started drafting in April of this year. And the three of us worked together. And as we were working on this op-ed, which is all about the need to democratize, decommodify, and remediate, and I'll tell you shortly about each of these principles. But as we were working on this op-ed, we also noted that women were underrepresented pretty much across the world. In the group of experts the media were turning to try and better understand the economic, social, political implications of this crisis. So once we had our first draft of the op-ed, we turned to a group of 9 women, all experts in their academic field, and we ran the op-ed by them and asked them whether they would be interested in signing it. And their reaction was that, yes, they'd be delighted to sign it, but that we shouldn't stop at that group. What they wanted to do is circulate the document across larger groups in their academic communities to see what people would have to say. And what happened as a result of that is that over the course of just 2 weeks, the document was circulated among thousands of academics, researchers across the world. These researchers translated the article, contacted the newspapers, and the op-ed came out on May 15 simultaneously on 5 continents, in 43 newspapers, in 36 countries. It was signed by over 5,000 researchers and academics. And if you have an interest in these issues, you can find all the information. We've created an initiative, the Democratizing Work Initiative. If you're interested, no matter whether or not you're a researcher, you can sign. If you don't agree, you can participate in the debate, because we need to think together about how we can rebuild and what we can do. Now, what we did as well, because we had a lot of demands, is that we wrote a book. It first came out in French. We just finished the English version of that book, so hopefully it will come out in the US soon. But we wrote that book to help people better understand these core principles of democratize, decommodify, and remediate that are rooted in the research we've been conducting. All the co-authors on this book are the women who were part of the first group of experts we turned to. So it's a book written by women for other women, but much beyond that, to help all of us think and engage into this thinking on the future of work and how to rebuild. So let me say briefly a few things about each of these principles. The first one is about the need to democratize firms, which is all about giving power and voice to employees, including to women, obviously employees, who too often are underrepresented still at the head of their organizations and on boards. So why democratize? First, because of social justice, right? The capital investors are represented, but the labor investors, the workers, are not represented on the board, which is the place where all the strategic decisions get made. Now, the other reason why we should be democratizing is because it is time to combat excessive concentration of power in the hands of shareholders. I study power and politics. What's very clear, and we know, is that when people concentrate power in their hands, no matter what, they tend to abuse that power. That's always a risk. If you leave all the power in the hand of shareholders, no surprise, you get to a system of shareholder value maximization. What is at stake now is rebuilding some kind of a balance and keeping their power in check. And then last but not least, what I see in my own work is that the organizations that have more democratic ways of deciding, making their critical decisions, these organizations are better able to pursue social and environmental goals alongside financial ones. Now, let's go beyond that and think about how can we democratize? Well, it's about giving workers power. And when I say workers, again, it's men and women. And we have to be thinking also across different groups and demographics in the organization, because some groups are underrepresented among the minorities. So we have to think about making sure that we get workers to be represented on the board, and they should have a real say, which means that just like the shareholders, they should have veto power. Now you'll be thinking, is that something that exists anywhere? Is it willful thinking? Is it even possible? Absolutely. It exists in Germany, where we have the system of co-determination. So what I'm talking about is nothing completely new. We do have research that has documented such systems, and we do know that such systems can be implemented. But again, it's about rebalancing power and distributing power differently. The second principle is about decommodifying work, which is recognizing that work is not a mere commodity, but that it is a right. So why decommodify? Markets are not neutral, they're not fair, we know it. In fact, if you think about women, for example, it is pretty clear that they've been discriminated against on labor markets, and the people on this panel today have conducted amazingly important research showing these things. So if markets were fair, we would know it, but if we leave it to market to decide for us, we leave it in fact to the powerful people on this market to decide for us. Now, the other reason why we need to commodify is because one thing we've learned from this pandemic and what it has reminded us is that there are sectors we need to protect from the sole laws of markets. And I'm thinking about education and healthcare. When you don't protect certain sectors, inequalities get to further and further increase. And last but not least, when I talk about work as a human right, I'm referring to the Universal Declaration of Human Rights, Article 23. Work is not a mere commodity, again, it's a right. So now, how can we decommodify? Well, it's about allowing everyone access to a job that enables them to ensure their dignity and to provide for their community. And here again, if you look around in a number of countries throughout the world, you can see at the moment people experimenting. Job guarantee programs exist. And now what's at stake is for all of us to think together about how can we scale them. And as we scale them, we again have to be very careful. We have to make sure that we include all of the groups. And when it comes to women, we have to think critically about how we make sure that they're not going to be disadvantaged, but on the contrary, that such programs will enable them to play the critical role that they should be playing without having to constantly worry about being in precarious kind of situations. Now, finally, remediating the environment. It's all about committing to preserving our natural ecosystems. Why remediate? It's pretty obvious. We do have all the scientific data. Now, it's a real existential threat for us and for all the species on the planet. We're already feeling the consequences of climate change in our everyday life. Think about, for example, the fires that have happened so recently in California, in Australia, other critical weather events that are affecting all of us. So now, how can one remediate? Well, critical aspect here is that one thing we're going to have to do, among others, is require that workers from specific sectors transition, right? They migrate from more polluting sectors to greener ones. And as we think about that transition, we have to make sure that we provide all the safety, the dignity that's necessary for workers to transitions. And that's why we need to decommodify. That's why we're going to need all of those job guarantee programs that I just mentioned. And then importantly, it's also going to require that companies transition from the model of shareholder value maximization to a model that accounts for their social and environmental impact. And here again, I'm going back to the research I've been doing. The organizations that are more democratic, that have already democratized, are better able to do that. Importantly, among the ones I've seen, women are represented on the boards and on all of the groups that are making the critical decision. So based on all the work I've seen, the work of other people, I think we have reasons to hope, but the changes I'm talking about require a transfer of power. It's never easy to implement these changes, but I'm hopeful because we have models. And so we're not only agitating against the status quo, now we can innovate, and the next challenge will be to orchestrate the change. Thank you.
Thanks so much. That was just a fantastic presentation and a kind of remarkable story of how you have used your scholarship to develop both a understanding of what's happening in the pandemic, what it reveals, and what people can do about it. And I think one of the most impressive things that Ingrid and I have found in putting the course together is this relationship between universities, university scholarship, academic research, and trying to both remediate the pandemic, but also think in terms of different forms of social advocacy around the problems that the pandemic has clarified. So I congratulate you on this work. It's a great story of how thinking about things can take off. And we've seen a lot of bad representations of social media, but here's one in which your ideas and thinking with your colleagues has really reached an incredibly broad audience. So it's very gratifying to see such important work reach such a big audience. So thank you very much. Our last speaker is Professor Sarah Richardson, and it's a pleasure to have you here today. Thanks so much.
Thank you so much. Good morning, everybody. Let me just get this. Here we go. Okay. So as Alan mentioned, I am the director of the Harvard Gender Sci Lab, which is an interdisciplinary collaborative space that brings together social scientists, philosophers, and scientists from a range of fields. And when the COVID-19 pandemic hit, one of the things that we took note of were the early emerging patterns that showed a much higher rate of poor outcomes for men compared to women. And this is really something that we specialize in, thinking about sex difference claims in a health and biomedicine context. So we started to examine those patterns and try to understand them with respect to the existing public health literature and our own understandings of how sex and gender interact to produce health outcomes. So the headlines shown on this slide exemplify how biological sex has been foregrounded as a primary explanatory factor in these COVID-19 sex disparities. I'll note that early on in the pandemic, the ratio was as high as 2-to-1 in male deaths to female deaths in China, in Italy, and in the early surge in New York. So there's a very concerning disparity in outcomes. So biological sex has been foregrounded in explanations of these differences in rates of mortality due to COVID-19 between men and women. Now, a concern is that a focus on biological sex can obscure gender-related and other social factors that are potentially as or more relevant than biological sex in shaping vulnerability to COVID-19. And so in this presentation, I'll be centering gender and other social and demographic variables to offer alternative ways of understanding, investigating, and talking about inequities in the pandemic. So there is some key terminology that you'll need to be acquainted with for the approach that I'll be taking in this presentation. So most of you have probably heard of gender and sex and the distinction between them before. Gender referring to cultural conventions, roles, and behaviors for, as well as relations between and among women and men and boys and girls. Sex, in contrast, referring to biological characteristics enabling sexual reproduction, such as gonads and chromosomes. The term gender sex might be unfamiliar to many of you, but it is a central construct for the work that we do in the lab for thinking about disparities between women and men. This is an umbrella term for both gender, i.e. socialization, and sex, evolved biological traits, and reflects social locations or identities where gender and sex cannot be easily or at all disentangled. And using the term gender sex rather than sex or gender, as I will often do in this presentation, calls attention to two critical points. Even in cases where it is theoretically possible to do so, we currently lack the data needed to separate the effects of gender and sex. And without such disaggregation, the term gender sex is more appropriate than sex or gender to describe these findings. Gender sex also highlights the need to insistently pair sex disaggregated COVID-19 data with social variables and other demographic variables such as age in order to identify tractable points of intervention into disparities in the COVID-19 epidemic. Now, one thing I want to note before I go into further discussion as well is that I'll be discussing public health data and public health agencies, most of them, very, very few exceptions, collect data on COVID-19 using a binary model of gender sex, female, male, and women, men, and disaggregating data this way into male and female categories, of course, will exclude or miscategorize many individuals. And as a result, there are critical gaps in knowledge about COVID-19 and the way it impacts intersex, trans, and non-binary communities. And I'll be happy to answer questions about that in the discussion. Disparities in COVID-19 outcomes between men and women. This is some data from the Harvard Gender Sci Lab's US Gender Sex COVID-19 Data Tracker, which shows that there is significant variation in mortality across geographic locations in the US alone. So if there is a biological sex disparity in outcomes, one would expect it to be quite stable, quite a bit more stable across localities, geographies, and social locations. So how do we explain this variation? Why is it that in Massachusetts, for instance, women are more likely to die than men, while in New Jersey and DC, men are much more likely to die than women? Why is it that mortality rates are so close for women and men in Kentucky? We also have this data longitudinally, and I'll be happy to answer more questions about this project. This graph shows the ratio of age-adjusted mortality rate among women over the age-adjusted mortality rate among men over time, and how this is basically how this has changed week to week. And each of the lines represent a different US state. A ratio value of
Oh.
to context-specific social factors to understand what truly lies behind gender sex disparities in specific localities. Okay, so we also know that there's great variation in COVID-19 outcomes across social groups. So racial disparities in COVID-19 outcomes have drawn attention to how the legacies of structural racism and white supremacy contribute to health disparities, and racial segregation in housing, zip codes, and occupational roles correlate with increased risk of death from COVID-19. For example, Black and Latinx Americans are overrepresented in all healthcare support and personal care service occupations, as well as in many high exposure professions such as food service, transportation and delivery, manufacturing, construction, and security services. Here's some new findings from our lab. We are the first to look at the intersection of race and sex, and there are only 2 states reporting data that would allow us to do that. That's Georgia and Michigan. Our analysis of data coming from these 2 states reveals that, number one, Black women have died at higher rates than white men, okay, in both locations. And therefore, what we see here is that the mortality rates of men are not universally higher than the mortality rates of women. But furthermore, the gender gap varies in magnitude across social groups. Gender-sex disparities among Black Americans are greater than they are among white Americans. And I'll turn to some possible explanations for this in a moment. In light of this variability, sex-linked biology seems inadequately positioned to explain the differences observed between and within racial groups in the US. Instead, we would expect the root causes of such disparities to be complex and likely linked to occupational exposures, histories of discrimination and resource deprivation, socially rooted differences in comorbidities and healthcare access, and other contextual variables. Here's another question that we might ask. How reliable, complete, and valid is our data on COVID-19 outcomes among men and women? So here is a graphic that's gone around quite a bit, showing really dramatic differences between outcomes for men and for women. Now, this is a case fatality rate graph, and what we need to note is that case fatality rates are not the same thing as mortality rates. They are a different construct. A mortality rate is the number of deaths from COVID-19 in a particular population scaled to the size of that population. A case fatality rate represented in the figure on the slide refers to the number of deaths among confirmed cases. Now, case fatality rates are calculated by dividing the total number of confirmed deaths by the total number of confirmed cases. And in the case of COVID-19, gender-sex disparities, case fatality rates for women and men are calculated by dividing the number of women or men who died from COVID-19 by the total number of women in one case or men who were diagnosed with COVID-19. Obviously, a key assumption of this is that for case fatality rates to be accurate and reliable, COVID-19 cases among women and men have to be detected at an equal rate. However, we know that certain groups are more likely to get tested for COVID-19 than others, and that factors related to gender sex influence access to tests, or even the simple likelihood that a person gets tested. And so we can look at how the striking disparity seen on the previous slide between the pink and blue bars, although it would be likely enough to convince anyone that gender disparities in COVID-19 mortality are great and perhaps insurmountable, we might consider that, for instance, pregnant individuals and healthcare workers, both of whom are overwhelmingly female, are more likely to get tested for COVID-19. This increases the likelihood that asymptomatic and mild cases of COVID-19 among women are detected. And with more cases being detected, the total number of women who die from COVID-19 might appear like a small fraction of all cases, hence the lower case fatality rate for women compared to men. This points to the necessity of carefully examining the social, economic, and cultural factors that can affect testing, and therefore metrics such as the case fatality rate. And to date, we really lack data on the testing rates for women and men, although some emerging data does suggest much more testing among women. Here's another question that we might ask. Examining pre-COVID-19 mortality rates in Massachusetts and comparing them to mortality rates during the COVID-19 surge reveals that compared to baseline conditions, i.e. Average mortality rates for men and women over the last 5 years for these exact same weeks in Massachusetts shows that there is a pre-existing mortality gap between men and women. This is work by Nancy Krieger out of the School of Public Health that shows that during the intensive weeks of the surge in Massachusetts, the mortality for both men and women went up, gap remained the same. Okay, the surge affected men and women equally. If this finding is generalizable, the disparity in COVID-19 outcomes between men and women does not have to do with a specific male vulnerability to the virus that causes COVID-19, but reflects a baseline propensity of men and women to die in any given year. So the dotted lines show the average mortality for women and men in Massachusetts from January to mid-April for the years 2014 to 2019, red for women, blue for men. And the solid lines show the mortality registered in Massachusetts for women and men this year between January and mid-April. Okay, so you can see the surge happening and the identical increase. So that is When we contextualize disparities in COVID-19 mortality between women and men relative to pre-COVID-19 disparities, that helps us understand relative excess deaths and where we should locate causality. Just a few more points. We are also concerned about undercounting of women's deaths. So according to the New York Times, as of September 16th, 2020, more than 77,000 residents and workers of nursing homes and other long-term care facilities have died of COVID-19. And the number reported by the Times is 40% higher than those reported by federal authorities on the same date, indicating significant gaps in data reporting about COVID-19 in nursing homes, and that this continues to exist. Considering that women represent about 70% of the US nursing home population, gaps in this data reporting could bias the conclusion we draw from current data. And this also could explain some of the variation we see among states. So I'll just skip over this for time. The wide consensus that nursing home deaths are undercounted. Now, how can we theorize then the role, what factors might be playing a role here? Well, we have a good historical reservoir of cases of pandemics with sex disparities in outcomes. And in an op-ed earlier this year in the New York Times, I reviewed some of these cases, and I'll just quickly touch on them here. Here is the flu pandemic of 1918, which has been widely compared in some dimensions to this current pandemic. In 1918, men also died from the flu in larger numbers than women, similar to what we're seeing now with COVID-19. There's been many excellent retrospective analyses of these patterns, which show upon closer analysis that this sex disparity was driven primarily by specific groups of men that were disproportionately affected by the flu because of their occupational status, a social variable. Men in the military and unskilled manual laborers died at much higher rates than the general population. And this was likely because engaging in social distancing was harder for men in these occupational categories. There were no sex disparities at the end of the pandemic in mortality from the flu among non-military upper classes, where men and women died at similar rates overall. And because of the other factor is that because of their more limited ability to socially distance, men also entered the 1918 pandemic with higher rates of TB compared to women. And this made them more likely to die after contracting the flu virus. So we see that in the 1918 flu pandemic, sex disparities arose mainly due to gender-related differences in both occupation and pre-existing conditions. I see that there's a message for me, but I can't view it on my screen. Let me know by hand signal if I need to wrap up. More recently, we can look at closely related coronavirus epidemics, similar patterns. Here's SARS in 2003, caused by another coronavirus. And during SARS, men also died at a higher rate than women. But sex differences in fatality rates varied significantly across age groups, and this provided a clue. The lower fatality rate among women compared to men could be found primarily among younger groups. And this was found to be primarily driven by high infection rates among healthcare workers, just as I discussed earlier. Healthcare workers were predominantly female, but also young and otherwise healthy. They were, in other words, more likely to survive a SARS infection. And the high rates of infection among healthcare workers created the illusion that in younger age groups, women were more likely to survive SARS than men. No significant sex differences in fatality rates were observed at older ages, and subsequent analyses accounting for age, occupation, and pre-existing conditions showed that men and women had similar fatality rates for SARS across all age groups. So once again, gender behaviors, pre-existing conditions, and gender-segregated occupational exposures proved to be clear in explaining the sex differences that puzzled so many at first. And there can be no more stark example than MERS, the Middle East Respiratory Syndrome, also a coronavirus outbreak in 2012 that primarily affected countries in the Middle East. And MERS also exhibited a pattern of higher male mortality, overwhelmingly affecting older men. And camels are the key source of infection Humans contracted MERS through direct or indirect contact with infected camels. And in Saudi Arabia, camel handling and slaughtering are primarily male occupations. Analyses accounting for age, pre-existing health status, and occupation have shown that fatalities actually do not differ from sex, even though 80% of the fatalities were among men. So sex doesn't account for this, it's occupation and pre-existing health status. Okay, you're probably already thinking of lots of gendered variables that could contribute to these patterns when it comes to COVID-19. I'll put a few of these out here. I know we need to move quickly. Gender and social factors most certainly are influencing COVID-19. Gender sex disparities. Polls have shown that men in the US are more likely to downplay the severity of the harm potentially caused to them by COVID-19. Men are less likely to wear masks due to the pressure to perform masculinity. Gender-related behavioral factors can influence compliance with other kinds of public health recommendations, including hand washing, proactively seeking medical help, and the observance of social distancing policy measures. Men in the US and across a variety of other geographical contexts have been found less likely to support and follow preventative measures of this kind and to delay seeking medical help when symptoms appear. In addition, men tend to have higher rates of tobacco use and alcohol consumption, both of which are considered risk factors for severe COVID-19 outcomes and increased mortality. We can look at gender segregated structures of high exposure jobs, which I mentioned previously. And on the other hand, that women staff the majority of healthcare support positions in the US, where they are more likely to get infected, but also more likely to get tested and more likely to survive given their health status. So I'll just highlight one more thing, comorbidities. Comorbidities highly correlate with COVID-19 outcomes. Here's just a selection, a handful from the CDC of disparities in comorbidities between men and women pre-existing in the population. The unequal distribution of comorbidities among men and women and across social groups likely influences these COVID-19 disparities. So in the US, you can see that men are more likely than women to have hypertension, heart disease, diabetes, and chronic obstructive pulmonary disease. Men are, again, more likely to smoke, make use of excessive alcoholic beverages, and all of these conditions are correlated with severe COVID-19 outcomes. Okay, so just to conclude, the sweeping claim that men experience poorer outcomes from COVID-19 than women is not true for all men in all localities. There's limitation on data collection that hinders our ability to draw strong conclusions about this, and this is what our tracker is trying to address. And prior experience suggests that social and demographic factors are likely the primary drivers of this disparity for men. Thank you.
Thank you so much, Professor Richardson, for that incredibly compelling talk. And thank you all to our speakers. I think you have highlighted some of the fundamental issues in this moment in COVID and also prior to this. And I appreciate in this last conversation, both the relevance of the intersectionality that we have to consider in this context, and also the differential that pre-existed in terms of mortality and these gender differences. So with that in mind, we have just a few minutes. Let's try to bring in at least one or two students to ask some questions. Yvonne, would you mind bringing in some students?